Great. Well, thank you, and welcome to CMTO's open house. Welcome to those of you who are in the room. Thank you for joining me today. I know there's a ton of other things you could be doing with your time, so I really appreciate you being here. And welcome to those who are joining on the live stream. So, a couple of things. This is the sort of the last in a series of open houses that started in Thunder Bay, and there's been a bit of a carbohydrate theme related to these open houses. So in Thunder Bay, there's a donut that you need to eat. I don't know if you've ever been there. It's called a Persian. And then, of course, when I was in Ottawa, I had to eat a beaver tail because it's apparently against the law not to eat a beaver tail in Ottawa. There were no donuts to eat that I could find in London, but of course Thanksgiving did involve a great deal of pie. So I'm just letting you know that that's been the theme of the open house so far, and it may be that I need to do a sit-up or two as a result. I'm Maureen Boon. I'm the Registrar and CEO of the College of Massage Therapists. A little bit about me. I am not an RMT. I am a regulator. So I worked for the College of Physicians and Surgeons for about 100 years, and then I worked for the College of Optometrists and now with the massage therapists. So regulation is my area of expertise. But I am a big fan of RMTs, and I am a fan of them for a couple of reasons, both in terms of the fact that I periodically need to use one for various sore bits, but also because I think that RMTs have a really important role in the healthcare system. They spend a lot of time with clients, perhaps more time than any other healthcare providers, and I think that that is really important in a healthcare system in which things are increasingly rushed and more sort of digitized. So a very important role for massage therapists. So today, what we're going to do is provide you with a few updates. We're going to have a little bit of a conversation, and I'm hoping that I can hear your thoughts about health history, and then anything else, of course, that you'd like to ask me, and I will be available afterwards. For those of you in the room, if you have questions, you're welcome to interrupt me as they come up. You'll just need to wait for Angie or Maria to provide the mic so that others can hear you. So, on that note, and now my slides are not advancing, so let's see what we can do about that. Hold on just a second. I can see if I can get out. No. All right, well, you know what? I'm going to keep talking while we work on that, or shall I wait? Let's see. Yeah.
The whole thing's just frozen. Why don't we get the other laptop up here?
Okay. All right, we're just going to switch laptops here because it wouldn't be an event if something didn't go wrong. Keeps it happening.
Okay. Why don't we, we'll have to unplug this down here. That might actually unfreeze this. We'll just see.
Try that.
Oh, we're back. Can I plug that back in?
All right.
Just give me a moment. I'm going to switch back to you.
Okay. All right. Sorry about that. And I just need to wait for the signal again. Okay. Sorry about that. Okay, so I wanted to start with a conversation about what the CMTO is and what it isn't. So we are obviously the regulatory body, and I'm going to talk to you a little bit about the CMTO's role, and particularly how it's different from the association. You know, the purpose of the College of Massage Therapists is to register massage therapists, make sure that they're ready for practice, to ensure that they continue to be professional and ethical throughout their careers, and to respond to issues as they arise. And we do that in the public interest. And this distinguishes us from the association, which is there to advocate for massage therapists, and that's an important distinction. And we do have Michael Faraday here from the RMTAO today, and he and I speak often, and we have a good relationship, recognizing the dual roles of the college and the association. So I'm going to talk about each one of these in turn. So first, speaking about registration, this gives you a bit of an overview of the number of registrants at the college. So we have about 15,000 RMTs in Ontario. That number has remained fairly steady over the last couple of years. We have about 800 to 1,000 new registrants each year. But what we have seen, so the profession is growing in terms of new registrants, but what we are seeing is more people leaving for a variety of reasons, including retirement, COVID, other reasons that are personal to them. So it's not just about the numbers, obviously. It's about ensuring that registrants are competent and ethical, and you'll hear me say that a lot throughout this presentation. And from a registration perspective, we really are thinking about what students need in order to be ready for practice. So we think a lot about the quality of their educational programs. We have our exams, the MCQ and the OSCE, which I'm sure all of you recall in the room. We have a newly developed Jurisprudence Program, which I will be speaking about later in the presentation, and we also do a vulnerable sector check, which is unique amongst other regulatory colleges. So next is with respect to quality assurance. So we have really been working over the last year to try and modernize our approach to some of the processes that you will interact with as an RMT over the course of the year. So we have done a lot of work in response to feedback to simplify the Strive Be the Best You Can Be program, which opened recently and closes on October 31st. If you've had an opportunity to do your Strive requirements, hopefully that you have found the platform a little bit easier to work with, because we did do a fair bit of work to try and simplify both the requirements and the experience on the platform. We launched the optional Jurisprudence Program, so it's available to anyone in the profession at the moment, but it will be a requirement for new students in 2024. We streamlined the professional liability insurance requirements, so you no longer need to upload them. You do need to have insurance, obviously, but you just need to demonstrate if we select you to confirm that. And we have done a fair bit of work to improve the registrant portal. We did have some problems last year with respect to people having to reset their passwords a lot, and we have had fewer problems with that this year, and hopefully that's been your experience as well. So next I want to talk to you about that third part, which is responding to problems when they arise. And I'm going to be talking about two things. One is sort of the new cases that come to our attention. So these are the issues that are brought to our attention. And most of them go forward to our Investigations, Complaints, and Reports Committee called the ICRC. And the ICRC can do a number of things. It can take no action. It can remind the RMT about their practice. It can order remediation, or it can refer things to discipline for the most serious matters. So I'm going to be showing you two slides, one with respect to what comes in the door, and then also the matters that come to, that are considered by our discipline committee, which is more like a hearing, much more serious and significant process there. So a couple of things that are notable about this slide. One, and these numbers. One is that 151 new cases in 2022 in a population of 15,000 RMTs is a pretty low number overall. So that's an important thing to keep in mind. The other thing is that you'll see that from left to right on this slide, you know, the majority of matters that are coming to the college's attention are about professional conduct. They're not about clinical care. So sexual abuse, fraud, and professional conduct and behavior account for about 63% of the matters that come to our attention over the course of a year. The other thing that's important to know here is that this number of 37% of sexual abuse matters is high. It's high compared to other regulatory bodies and other health professions. And why is that? Partially because of the nature of massage therapy. So it is a touch-based treatment with spending extended periods of time with clients, often in isolation, and in a situation in which the client often feels very vulnerable because they are face down and not completely aware of what's happening around them. And you combine that with the Me Too movement and the fact that people are more willing to contact the college when they have concerns, that leads to this number of 37%. So, I mean, from the college's perspective, we want to hear when people are not happy with the care that they have received. And we also want to be working on strategies to prevent sexual abuse in massage therapy, and I'll be talking a little bit more about that later. The last thing I'll say about this is that the definition of sexual abuse under the RHPA is very broad. So it extends all the way from the most serious matters of true sexual assault all the way to comments, inappropriate comments about a person's underwear or tattoos or that kind of thing. So there is quite a large range what's included in that sexual abuse number. So if we move on to, remember I told you that matters are first considered by our ICRC, and then the most serious matters are referred to our discipline committee, which is, as I say, more like a trial, more like a hearing. And you'll see that here the same number of sexual abuse, fraud, and professional conduct behavior are now 88% of the matters that are considered by the discipline committee. So the ICRC refers about approximately 20 matters to discipline committee in each year, but in 2022 there were 76 open matters at discipline. So that gives you a sense, again, of the kinds of matters that are coming to our attention and what they are about and the volumes. And why is this important? Well, it's important because these matters have high impact. They have high impact for the clients, obviously, particularly with sexual abuse. There's a significant breach of trust. They're high impact for the registrant because at discipline, this is a high stakes matter where their ability to practice is potentially in jeopardy. And also high stakes for the CMTO. Sexual abuse matters are complicated and challenging to investigate and to take to hearing. So they have impact on everyone. So that's one of the reasons why we identified sexual abuse prevention as one of the key areas that we wanted to focus on in our strategic plan. And, you know, it's not just about education or rules. These things are important, but it's about understanding and avoiding the behaviors. So I'm going to talk about each one of these strategic directions: sexual abuse prevention, engagement and partnerships, regulatory excellence, and equity, diversity, and inclusion. So on sexual abuse prevention, we are going to be bringing together a group of various people and organizations in November to talk about some strategy for preventing sexual abuse. So we're going to include educators, the association, some other groups, and really it's a chance for us to hear from others about what they think might be some of the some strategies for preventing sexual abuse, because of course, even though we need to respond to these things, it would be better if we could work on prevention, particularly on some of the behaviors that are avoidable. And we've included lots of different people because we know it's not a problem that only the CMTO can solve. It's a complicated problem with lots of pieces involved in it, and we're looking forward to hearing from others on this. Our Jurisprudence Program that I mentioned also has a sexual abuse module that's included, and this will be a requirement for all, as I say, for all new applicants in 2024. The last thing I'd say about sexual abuse prevention is that we want to be looking not only at sexual abuse by RMTs, but we also would like to have a conversation with the profession and with others about some of the sexual harassment issues that we've heard of RMTs. And that's something that I've heard a little bit about in the open houses. It's not good, and I would, I'm interested in having a conversation about that. Next is the second piece that we're focusing on is engagement and partnerships. So days like today, obviously, we have a concerted strategy to engage with educators in particular, because we are very interested in that prevention and quality of education piece of things. And we have been having open consultations, which I would encourage you to respond to, because we do pay attention to that feedback, as you saw with our Be the Best You Can Be. All right, next on the list is regulatory excellence. So this is really the CMTO's efforts to focus on improving efficiency across all of our programs. So I mentioned that discipline is a bit like a trial. It's a complicated and expensive process, and we are working on a pilot in collaboration with the College of Physicians and Surgeons to use experienced adjudicators to assist with managing some of these higher stakes matters. And we are looking for a different way of managing these hearings, and we will see how that goes. That pilot should be evaluated over the next year and a half. We're going to be reviewing our investigations process to see if there are more efficient ways for us to deal with those complaints that come through the door. As I mentioned before, we have made improvements to the STRIVE program. And last but not least, we have been focusing for some time now on working towards requiring accreditation for educational programs in Ontario, because of our belief that the quality of education and consistency of education really helps to set students up for success once they become registrants of CMTO. And last but not least is equity, diversity, and inclusion, which is something that the CMTO has really just started some work on. So we've done some education on things like use of gender pronouns and gender expression, Indigenous issues, bias. So we've been working on that internally. We also want to be looking at getting some more information about the diversity of the profession as it relates to the diversity of the public. And we also want to be looking at the diversity of our board and our committees at CMTO, because we know that having diverse opinions leads to better decisions and better conversations about a variety of issues. So stay tuned, because we're going to be working more on this. So one of the things that I wanted to talk about is is to talk about the requirements to be a registrant of CMTO. And there are 3 main requirements, so you will be well aware of the Be the Best You Can Be. That happens in the fall. In March, you did the risk-based assessment, so you did your practice profile and your standards of practice quiz. Be the Best You Can Be is now. And obviously, registration renewal has opened. We have been working quite hard to try and spread these requirements out through the course of the year. We haven't been 100% successful this year with respect to RBA, which I can talk about later. But the idea here being that we want to make sure that these requirements don't overlap as much as they have in the past. So we have been working on that. And the last thing I would mention here is with respect to when requirements are missed. So most RMTs meet all of these requirements. They do what's required of them on time, but a small proportion do not, and the CMTO spends a great deal of time following up with those people. So it has consequences for the CMTO, and it obviously has consequences for the individual RMTs because there are fines for late completion, and there can also be consequences in terms of suspension. So one of the things that we are sometimes asked is, how can I avoid receiving a complaint and being one of those numbers on the slide that I provided previously? And we know that RMTs are interested in providing good care. And we want to support you in providing good care because that is in the public interest. And, you know, the top 5 things that come to our attention and the things that registrants can easily avoid are laid out here. So keeping accurate financial records for clients. So this is making sure that you are in control of your billing number. It's not being used for other purposes. You are billing appropriately, and you're keeping accurate records. So that's because we do get complaints about fraud, as I mentioned previously in the presentation. Maintaining up-to-date and confidential health records, also obviously very important. Obtaining informed consent. So this is critical, particularly as it relates to the prevention of sexual abuse. And this also relates obviously to the sensitive areas consent form, which is really intended to ensure that clients are not surprised by areas that are touched. Because I can tell you that when that happens, it can result in a complaint, and that can be easily avoided by having that conversation so that people know which areas are going to be touched during the course of the treatment and that they consent to those areas being touched. Maintaining professional boundaries, very, very important. And if I could put this another way, I would call it wait to date. So this idea that you really need to wait to initiate a sexual relationship with a client until a year has passed. It's really important because if there is overlap, it can result in complaints. And last but not least, as I mentioned before, complete your strive and renewal on time. So those are sort of our top tips for not having more interaction with CMTO than you might otherwise want, even though we are very nice, and otherwise I'm sure you'd like to hang out with us. Okay, so next, with respect to the STRIVE program. So I talked a little bit about this before. So what's the purpose of quality assurance? So at the beginning, I talked about our key roles being registration, quality assurance, and investigation of matters that come to our attention. So on the quality assurance side, The purpose of the quality assurance program is to make sure that RMTs know the standards and are professional in their practice. And this helps to avoid, because we want to help avoid problems. And that's the purpose of quality assurance. The goal is not gotcha. We're not trying to catch people out. We're trying to support people to provide competent and ethical care. So, you know, we have structured the STRIVE program so that right now, when you're doing the Be the Best You Can Be, you get notice of the 4 standards of practice that will be the subject of the standards of practice quiz that happens in the spring. So when you do your e-learning module, you have an overview of those 4 standards of practice. You know what they are in advance. You have an opportunity to learn them and know them, and then the expectation is that you will demonstrate that you know them during the risk-based assessment that happens in March. So really the program is meant to fit together like that. As I mentioned, we made some changes to Be the Best You Can Be, trying to enhance the user experience, aligning people so they're all on the same cycle. We removed the experiential learning exercise. And we simplified the self-assessment. It used to have a lot of criteria. Now it has fewer. So hopefully you have seen the benefits of that. And the select standards of practice for 2024 are set out here: consent, fees and billing, collaboration and professional relationships, and conflict of interest. And you'll see that the selected standards of practice are actually related to some of the concerns that we see coming in the door. So consent in particular, and fees and billing, which relates to fraud. So really important for people to know their standards of practice. And may I just say, based on the results from the standards of practice quiz that everyone did in the spring, we know that the vast majority of RMTs do know the standards of practice. And that's great, because that's exactly what we're hoping to achieve with this program. So, switching gears a little bit, the college cares a lot about professionalism once people are registered and RMTs, but we also care about professionalism prior to registration. And I wanted to tell you, if you're not aware, about a little bit of an exam, not a little bit, but an exam cheating situation that we dealt with last year that has had significant impacts. So what happened was, in July of last year, we had evidence of cheating. And the cheating that we saw was as a result of exam prep courses that were run by RMTs, where live content from the OSCE was being shared with people in those prep courses. Now, this is a significant problem. It gives an advantage to the people who have access to that material, which is unfair to the people who do not have access to that material. So we needed to investigate this, which we did. And as a result of this investigation, some of the people who took the OSCE in 2022 had their exam scores invalidated, which is a big deal. For those of you who remember the OSCE, it takes a lot of preparation. There's an expense associated with it. So it had significant impact for people who were involved. And it also had impact for the college, because this was an expensive investigation that we had to undertake, and we are still dealing with the consequences today, because now some of the people who had their exams invalidated have now rewritten the OSCE and will be coming forward to our registration committee. As well, we are continuing our investigation into the people who were running the prep course. So this is just to say that professionalism is really important prior to registration and obviously once you become registered with CMTO. And this is one of the reasons why we think the Jurisprudence Program is so important, because it does have, it deals with both professionalism and ethics, and it also deals with the standards of practice. So this is going to be a requirement for all new registrants as of January 2024. It's available actually to everyone now, in case you want to take a look at it. But it will be a requirement so that ultimately everyone who is registered at CMTO will have been through that program. I mean, we know that some schools do a very good job of teaching professionalism and ethics in the course of their programs, but not all do. And we want to make sure that we're preventing problems prior to registration, and really the Jurisprudence Program intends to level the playing field for applicants to the profession and set the graduates up for success in their careers. All right, so I wanted to have a little bit of a conversation here about collecting health information. So you will have seen in an email that we sent out last week that we have raised the issue of some difficulties relating to the collection of health information. So just to begin this conversation, I would say that my sense, having spoken to a number of massage therapists across the province, is that everyone is using a form of some kind in their practice, even though the CMTO has not mandated that a particular form be used. We used to previously, but we don't now. At the moment, what the record-keeping standard of practice says is that you need to use your judgment in terms of the collection of health information. Some people, I have also heard, have been basically using the same form that they received when they graduated from school. So it hasn't changed for a really, really long time. And some people were taught that collecting more information, the more information you collect, the better. Safer to have more information, ask more questions as part of the health history. And this is a problem. And this is a problem for a number of reasons. And I'll talk about those. One is about PHIPA. So this is the section from PHIPA, which is the Personal Health Information Protection Act, which requires health professionals not to collect, use, or disclose more personal health information than is reasonably necessary to meet the purpose of the collection, use, or disclosure, which is a complicated way of saying this. Only collect the information you need to provide care. And so this is the reason why we sent out the communication last week, because there is sort of a widespread practice of collecting more information than is required. And we want to have a conversation with the profession about what information actually is required to provide care, because we know that there is information that's incredibly important for you to provide good care to clients. And we provided a particular example with respect to HIV. And we did ask the profession to remove the question relating to HIV from any form that they might be using. And why is that? Well, because of a few things. HIV status is incredibly sensitive information. It is not required in order for you to provide good care. So it doesn't comply with PHIPA. There is a potential for discrimination and stigma for HIV patients, which is a significant problem. And there's also the fact that once you collect sensitive information, you have more of a risk of, if that information is compromised, what you need to do to address that, a breach of privacy, is a more significant undertaking. So that's sort of the reasons why we've focused on HIV. And one of the questions that I have received is about, okay, well, what about, risk of transmission? So we want our policies and our approaches in massage therapy to be evidence-based. And the evidence is that the risk of transmission from skin to skin with an HIV patient is 0%. And even if you are doing acupuncture, which is a small proportion of the profession, the risk is less than 0.25%. So this is an important piece of information with respect to maybe some of the reasons why people thought they needed to ask for HIV information in the past that really don't hold up. But it's not just about HIV. Obviously, there are other categories of information that are routinely being asked for on health history forms and as part of these conversations that may also not be necessary in order to provide good care. So for example, mental health conditions, right? So let's talk about whether or not you need to know all of a person's mental health conditions before you can treat them. Or an entire drug list, right? Do you need to know every drug that a person is on? Or do you need to know the drugs that might lead to bruising, skin sensitivity, low blood pressure? And is there a better way to get at the information that you actually need instead of asking for a laundry list of every single thing that a person has been on? So these are the conversations that we'd like to have with the profession over the coming months in order to develop some new guidance about a better way to collect health history information. So again, the standards of practice say you have to collect relevant medical history. There is obviously medical history that is very relevant to the provision of massage therapy. You need to use your judgment. So what we're trying to do is come up with something that's in between a very rigid template that is over-inclusive and includes basically aligns with the more is better on collection of information. That's on one side of things and provides no flexibility. On the other side is just use your judgment, which can be scary for some people, particularly if they're new grads and they're not really sure and they don't have the experience about what is relevant. So can we come up with something in the middle that is perhaps a way to facilitate the conversation about health history without risking overcollection? So on that note, I wanted to have a bit of a conversation with you about what health information you think you need to provide safe treatment to the client. So if you want to just put up your hand and a microphone will come to you magically from. Just wait for the mic, or otherwise people can't hear you.
Thank you.
Okay.
Even though we give the health history form, which is somewhat standard, the clients are not filling every part. They are filling the part which we see is necessary. Still, we tell them, but sometimes they don't know even the phone number of the doctor or the full name of the doctor and where at his clinic at, or so many things which is related in the forms, like a standard from the school or from the website of CMTO sample form. I don't think there's all the RMTs, I don't know about it, but still they are not completing all the parts of the form which we use now.
Right. So I have heard this before, which is that so I've heard two things. One is that some clients don't really understand why massage therapists need to know all that information. So part of it is, I think, education about the clinical nature of massage, right? Because some people will say, I'm just here for relaxation or whatever. you don't need to know all that about me. So I think part of it is about having that conversation about why that information is important and reinforcing the clinical nature of massage. The second thing is that, I mean, you all know that not all clients fill out all parts of that form, right? And so the idea that you ask for everything as a way, as some kind of insurance against problems later, it's kind of a false sense of security, right? And the last thing I would say is that forms are meant to be a way to have a conversation. They're not meant to be a standalone thing that just goes in your chart and you don't, they need to be tailored to the client before you, because there will be information about health history that's really important for one client and not as important for another. So again, what we want to do is have some conversations with the profession about how can we get to a better way of having that conversation about health history so that you're not collecting the same thing from every single person all the time. And we're open to ideas about that.
Good morning, Maureen.
Hello.
For the record, Kevin Bruff here. I don't like doing this, but I'm going to quote it. According to some of the stuff I've met on Facebook, because I am not a HIV specialist, I try to think of myself as a fascial specialist. The keeping of records for medication is vital, according to what they have been writing, because as you said, the side effects. And you only listed bruising, low blood pressure, and sensitivity as potential bad side effects. So I'll just say, according to Facebook on the HIV topic, we should be collecting a complete health history on that topic. Not my opinion, the opinion of others. After 25 years, Kevin Bruff, devil advocate, I don't like that term. I prefer to say it as, I used to teach safety to the stupidest and highest standards. I used to work whitewater canoe climbing with police, military, fire. So as far as I'm concerned, in the last 25 years of my practice, based on the new concept of biopsychosocial, any information, you have no idea where it's going to lead. Any information will help you take care of a person in a safe manner. It is up to you to keep it private, and it is most importantly up to you to know when to refer. Because if you take Eric Purves or anybody's new concept of pain, our definition of our scope of practice is treatment of pain. Pain is mostly not a nociceptive thing, which we're taught at school. It is mostly another thing. So if we're not collecting information to know when to refer out of our scope, social work, psychology, or when not to modify our language around sensitive groups, you're one of the things that you mentioned earlier, which is a very wide scoping. Why are we trying to limit the capacity to be safe, inclusive, and be professional like all other RHPA members?
Okay, thank you for that comment. So a couple of things in response. One is, first of all, RMTs are not the only profession that collects health history, and is also not the only profession that is probably over-collecting information under PHIPAA, right? But we are the ones who are trying to address this particular issue head-on. And I will say, we're not trying to say that you shouldn't collect information. What we are saying is the collection of that information from every single client, every single time, which is what that form and the way people use the form does, is not appropriate according to PHIPAA, because you do not need to know someone's HIV status in order to treat them. Now, that doesn't mean it might not be relevant in some circumstances, but you do not need it to treat someone, right? So, and lastly, I would say with respect to the drug lists, I think this is actually a challenge for the profession, right? Drug lists are complicated. I mean, I can't imagine that you have the time or the ability or the knowledge of someone's complex series of, so if they bring you the big printout from their pharmacy, right, which I have heard that that is happening with some clients, bringing the long drug list. I mean, your ability to actually determine which one of those drugs, given how complicated and ever-changing pharmaceuticals are, is a big ask from an RMT, right? And I think that we need to have a conversation about potentially a better way at getting at what you need to know, which is not necessarily the whole list. So those are my few comments in response to what you've said.
Can I respond to your comments?
Sure, and then we have another hand over there. Yep, go ahead.
You said a few things. I'm here for just relaxation. That's a whole topic on itself as to how the scope of practice is, and I find it very confusing from the CEO that runs our practice to use that as an example of a client complaint when we know we're healthcare professionals. And anybody who's been in school or just out of school knows there's no such thing as just a relaxation.
I would agree with you. I'm
Okay, so
reporting
I'm confused
on,
as to why you would quote that.
because I've heard it from other
I just said
RMTs, that's why.
HIV is not my specialty, but I can point you to dozens of comments on Facebook. So without listening to the rest of those who specialize in it, we have specialists all over Ontario. Susan Shipton, cancer, Denny Foucher, HIV. There is dozens of really educated specialists. Without conferring with the specialists, you just answered you don't need to collect information on HIV based on when I just said a lot of them are saying it's vital because you need to know the side effects of the medications. Some are good, some are bad.
Side effects of HIV medications?
Yes. So I, before you go out and say you don't need to collect that, I would recommend that you do further research into it.
Okay, well, we have done research and we have received information from experts in this area, so we can continue to have the conversation.
Okay.
But the request that was made in the email from us last week was to remove HIV from standard collection in every instance. And we provided the reasons for that. Over to you. No? Okay. Any other questions? Over this way, Maria.
I was just going to answer your question. Is that
Okay.
okay? Health information that you need, like previous surgeries, previous injuries that are, I don't know, could be related to the areas that they come in with concern, then it would be good to know if they've had previous work in that area.
Yeah, I mean, the other things that I've heard from other people, so I heard a lot about wanting to know whether or not people are actually on pain medication at the time of the massage, because that affects obviously their experience and that kind of thing. The other thing I heard a lot about is the surprise disclosure in the middle of the massage. Oh, by the way, you know, you say, what's this giant scar? And they say, oh yeah, that was, that was whatever. And you know, so this is part of the education of clients about the fact that that kind of information is really important for you to know in order to provide good care. And sometimes people don't realize that. And then you have to sort of say, okay, well, that's an important thing for me to know in order to make sure that I understand the sensitivity of that area or whatever it is that you need to know, because everything's connected. So, I mean, I think that kind of conversation, again, the purpose of the form is to ensure that the conversation happens, right? And it's not even necessarily a one and done conversation. It's a conversation that will evolve as you develop a relationship with your client, particularly if you see them on multiple occasions, and you learn more about them, and they come to understand better how important it is for you to know things in order to provide good care. So, all right. Anything else? Yes.
So I'm just wondering, is this also a conversation that is happening with other regulators that have overlapping scopes of practice, like physio, chiro, kinesiology, that type of thing?
So I did have so there is an organization called HPRO, which is all of the regulated health professions that come together, and I did raise this issue. I would say that not all of the other professions have a designated, or had a designated form, a template that was used. So a lot of them have standards of practice that are similar to what we have now, which says, use your judgment. And that is interpreted in a variety of different ways. Does that mean that they are not over-collecting information? It does not. I think there probably is a fair bit of over-collection that's happening, and I'm going to continue that conversation with the other professions. I think the thing for massage therapy is that the form that has been used and was required previously by the CMTO, so we recognize that, is so widespread and so embedded in practice, both at the educational level, at the exams, in practice, everyone uses that it is hard to ignore. And the fact that those things, that it's so comprehensive, and those things are asked of every client every time, as opposed to being tailored to a particular client, is where the problem lies. So further conversations, and I'm going to be continuing to talk to my colleagues as well in other professions. Okay. Anything? Oh, there's one at the back.
The last few words, I was out of the room. Anyways, in terms of collecting information, I think it's a slippery slope. When you say the RMTs need to use their judgment on what exactly to collect, I believe we all would agree to a certain degree that when somebody comes out of school, they have a very limited amount of information and judgment in regards to the professional application. The more experience, like anything in life, the more experience you have, the better your judgment in certain areas will be. So having said that, I think it would be a rolling kind of a situation to collect information, and perhaps each RMT will collect information at a certain treatment stage in time to begin with, to address perhaps a certain issue while the client is coming in. And later on, if you're doing either recovery work or continuation of the same issue, you will get eventually more information and more knowledge about the circumstances, what you're treating the client for. So I don't think it's an open, closed book in terms of collecting information because it's an ongoing process in most cases. So I think you can determine definitely across the board what should be collected and what shouldn't, because the RMT might not have the knowledge at the time of treatment.
Correct.
While somebody else in a profession longer might have, like 10, 15 years from now, might have a better sense of how to treat and how to deal with certain information of the private information you're getting from the client.
Right. And I think that's an important point about the ongoing nature of the conversation, right? And as clients' circumstances change, or they feel more comfortable revealing more information to you, particularly about things like mental health, for example, that might be, so, maybe you don't start with that, right? Maybe you wait until you have a bit more of established a trust relationship. Or maybe you ask the question in a different way, which is there anything that that I need to know about you that makes you, particularly stressed, or areas that, there might be a different way that you can have the conversation. So what we're trying to do is to see if we can come up with some new guidance related to health history over the coming months in consultation with the profession.
Again, I think I agree with you. The way the RMT is asking the patient in terms of knowledge and information. For instance, I seem to have the habit of asking the patient when I see them the very first time, what is your concern today? Meaning this specific time where you're in my office and you're treating the person. What is your concern today? Your concern last week might have been different. Your concern from 2 weeks from now might have been different after you had initialized treatment with me. You might have had some other treatments with some other individuals whose practice is very different. The application of a treatment is very different. So I think that is a small little example of how to ask a patient about information and then go from there. Thank you.
Right. Thank you for that. And I think it shows sort of the judgment that comes with experience, right? Which is not always present right after graduation, and how can we find guidance that sort of helps everyone along that continuum. Over to you.
Based on my experience, what I realize is that we have to remember that the clients are the expert of their care, what they want. They came to us. And many times during the initial assessment, we don't have enough time to build that trust. So even though there's a standard form, or there are many forms that we choose to use, we may not always get the information that we're seeking. So for the benefit of those who have been in the profession long enough, we do have that sense of discernment to know what type of question, how to frame those questions to get the answer in order to get that treatment done. What I'm finding is that because I'm working in a clinic, there are many of us. So if there's initial form that was completed with the assessment, other RMT may not be keen or may not be too interested in saying, okay, well, let me dig a little bit deeper in this, or they may just do a massage. And if I'm seeing that client for the first time and I'm reading the notes, I need to make sure I'm protecting myself and I'm going to provide the best care for my client. So I'm going to ask certain questions. Now, the difference between recorded response to question and question that I need in the moment, I think that's where we need to be careful of. So if a person discloses to me that I've had a surgery, here are my medication, in this moment, to me that's relevant. I'm going to add that. If someone says to me, I am, due to COVID, I've been isolated, my doctor just gave me some antidepressant, today is not a good day for me, that's relevant information for me to know how to address the client. That's not information I will choose to dictate to say, okay, well, what medication are you on? It would be more, how am I going to tailor my treatment? How am I going to be in that moment with the client to provide the treatment that she needs so that she can be okay? And I feel that I've done my due diligence. Now, on that same note, regarding notes taken to provide that to the RMT that may have this client in the future, I will then be able to write in that space, not necessarily disclosing anything that would be jeopardizing to the client to expose her, but to just say, in this present moment, as I'm writing, I'm going to be mindful that I'm protecting the client. Client came in, wasn't feeling her best, maybe have a little bit of stress, work specifically on that. And then I put on a note again stating that client was pleased with the treatment. So what I'm doing is I'm building trust And my responsibility is to protect the client as well as to protect me, because I may not see that client again. So this is what we're talking about regarding how do we tailor a form. There will never be a form. It has to be internal, where we're saying, how can I provide the best care for the client in that moment? And also being respectful of the duty of my job.
Right.
That's what I do.
Thank you for that. I mean, I think that it kind of positions the form as a starting point for the conversation, right? Which evolves over time, which we've talked about a little bit. You also raise the issue of shared records. So I think that you raise some important points about, making sure that that information is accurate, but also you're being respectful of the client. I will say that you are all within the circle of care if you're treating the same client. So there can be, you should be comfortable sharing that information. The other thing I would say is that this is a big generalization, but I will make it anyway. Most clients think that everything that they tell to every healthcare provider, other healthcare providers already know through the magic of the cloud or something. And in reality, that doesn't happen, right? Like even when you access healthcare, healthcare providers, the fact that you have told this person this and that person another thing, the fact they always need to ask you again, right? And you can't assume that everyone knows things that you hope that the whole team knows. And so that's an important thing but really it's about the conversation, right? And I like your comment about focusing on what the person needs that day. And I think that there's I'm hearing a lot of experience in the room, and if we can sort of harness that experience to make the conversation easier for those newer to the profession, I think that might be sort of a perfect way to do this.
And as you said, new to the profession, I mean, the new RMTs. I was working in the field of paramedical more than 20 years, and now I'm working as an RMT only just 1 year. But when I graduated, I was in the station like there is a form to fill out the standard health history form, and we need to get all information from the client to fill. That's what, otherwise we won't pass the OSCE. There will be a question in the OSCE health history. This thing we need to fill out the thing as I said before. And as my colleague said, never be a form. It's internal, but it's not like that. I mean, but we need a standard form. Or we should have all the new RMTs must practice something like they should not be scared of taking all the details from the health history form, or they need all the details in the first visit, because we cannot get the client as a new RMT, like whatever is in the form is, the RMT is thinking that should be mandatory filled by the client. If not, there will be some actions coming in the later future from CMTO, or like if something like coming up. So there is a anxiety inside the RMTs, like who is having the forms, which even if any form, even from the anywhere, even if he decided, and the client is not going to fill all the things, like we insist them also, they will tell maybe in the ongoing treatment, they may expose, as you said, but still we are not able to get all the information what is in the form. But what we relevant for the treatment, we definitely collect, and we do get that in our mind, and we go and we sometimes note that is the things inside the SOAP note or in the health history form we are filling it. But as a new RMT, I think they are also intention like that. We need to, the CMTO need to clarify what all things should be mandatory in the health history form, and then we can discuss about what is not to be in, or which is not.
Right. So I hear you on a couple of things. One is, yes, the form, as I mentioned before, is deeply embedded, and it is, and we're going to be talking to educators about it, specifically about this, and what they teach with respect to the form, because as I mentioned before, the form does not exist on the CMTO's website at the moment. The standards of, it used to, though, and it did for a long time. So we understand why people used it. The standard of practice, as I say, says that you should use your judgment. You did say something as well there that I've heard elsewhere, which is this idea of if we were to go to new guidance and if it were to involve some version of a form, could it include some mandatory and some optional pieces, right? So, you know, that's something to think about. We can talk about that as we think about sort of where we go next with this.
So just to piggyback on that, are you saying the college doesn't have a plan to produce a revised form?
We have a plan to produce revised guidance that may or may not include, like, so we're really trying to avoid a rigid form that people sort of feel they cannot move from, because that's exactly what we had in place before. So, but we're open to ideas about what that guidance could look like. Maybe it's a discussion, you know, maybe it's a variation of what we have now, but it's like conversation starters. We're open to.
So a couple, just quick
Yeah.
questions then. So like who would make up the working group that would decide on these type of guidelines? And is there a hard deadline for these guidelines to be published?
Those are good questions. So no hard deadline. We wanted to deal with the HIV issue first, which we have asked people to do. And then I would say that our timeline is to have guidance developed next year. We haven't set like a particular date. In terms of who would be involved, we haven't quite figured that out yet. We do have some expert groups that we've convened for standards of practice in the past. So we might be using those as well, but I think we also probably will want to have a bit of a broader conversation as well. So if you have, if you're interested in that conversation, let us know, and we can certainly find a way to include, I mean, the goal would be to include as many voices as possible to come up with an approach that works for everybody. All right. If that's it on health history, I just have a couple of other slides, and then we're done. So just in terms of 2024, we are going to be continuing with those 4 elements of the strategic plan that I talked about. We're going to continue this health history work, as I mentioned. The Jurisprudence Program is going to launch in 2024, and we're obviously going to continue our focus on sexual abuse prevention. We anticipate that there will be a number of things that come out of our sexual abuse and prevention symposium that will be things that we will need to work on. And the last thing I just wanted to mention is to talk to you about getting involved with the CMTO. You are obviously engaged and interested RMTs, and there are a number of ways for you to become involved. You can run for the board. And I would note that we have Jay Mathers here today, who's the chair of our board. He's our public member chair of our board. But if you have any questions about what it means to be on the board or on a committee, he would be happy to talk to you about that. The nominations for district elections in districts 2, 4, 5, and 7 are due October 13th. The election date this year has been changed so to November 22nd. It used to be in January. We've moved it up so that we can be ready to start the year fresh. So I would encourage you to vote. If you're not a person who wants to run for the board, I would encourage you to vote and participate. You can also apply to be a non-board committee member. So to be on a committee like ICRC or the Quality Assurance Committee or those kinds of things, those applications, the deadline for those applications have passed for this year, but it might be something that you want to think about for next year. And last but not least, participate in our consultations, because we have moved to a more open consultation process, and which we have been using, and encourage you to participate there, because we do pay attention to the responses we receive. I will say that we don't always do exactly what everyone wants, because there are a lot of RMTs and a lot of you want different things. But we do listen to that feedback. And I just wanted to thank you again for coming today. It's really important to have these conversations. And if you have other questions, particularly if you're listening, you're observing on the live stream, you can email our practice specialist, or you can email the Office of the Registrar. Both of those email addresses are monitored and answered, and we'd be happy to try and address your questions. Okay.
Most RMTs for the future. Completely off topic, where does the college see itself in terms of financial responsibility in relation to the practicing RMT? Having quite a number of office hours under my belt personally, I find the registration renewal application and financial burden to the RMT has grown very large to this date from the time when I graduated, which is a while back. However, considering the economics nowadays, especially after COVID, that was a real challenge for most RMTs practicing with the general certificate, how much more can the practicing RMT afford for a yearly renewal for which we really do not get very much at all other than the tax receipt? We used to get some kind of an identification. For instance, myself, when I walked into a hospital for seeing a client or patient and doing some practicing there, I had some kind of identification that identifies me within the profession. Now I have a tax receipt. I get nothing other than the touch point every quarter or so on, and the correspondence in between 12 months of practicing. And then I'm paying my fee again. It's not so much of what I'm getting, but what I'm saying is, have you looked at the average price of massage therapy for 60 minutes nowadays that's being charged, in the relation to the annual fee the RMT has to shell out, plus liability insurance, plus office rent, et cetera, et cetera? Again, where do you see our budget going from here on for RMTs to be able to manage financially for all the requirements they're spending online before they renew their license, as well as in between the 12 months of practicing? Thank you.
Right. So thank you for those comments with respect to the renewal fees. The renewal fees are high, so I will acknowledge that, and they're high because of the number of matters that we deal with respect to sexual abuse in particular, and the number of discipline hearings that we deal with. Some professions, let me restate that. We're probably in about the middle of the pack for the 26 regulated health professions. So to your question about have we linked that to what a person's a health professional's annual salary is, no, we haven't. We don't have excellent data about what the annual salary is for RMTs, but it is something that we're hoping we can get more information about. I will say that the costs of regulation are independent of the salary of the profession being regulated. So all of the 26 health colleges have to provide those registration, quality assurance, and investigation activities, no matter what profession it is, whether they're an occupational therapist, a dietitian, or a doctor, right? So all of those things need to be provided. In terms of the value that we provide, this goes back to my original comment about the difference between the regulatory body and the association. The association is there to provide benefit to RMTs. That's why it exists. The CMTO's job is to protect the public interest, and it's a collective responsibility of all of the RMTs in Ontario. So we are not a provider of benefits to RMTs. It doesn't mean that we don't care about them and we aren't interested in their experience, but that's not our primary objective or mandate. So that's the distinction. And I think you may have asked a question about where fees are going in future. I talked about the regulatory excellence part of our strategic plan, which is related to ensuring that we are doing our best to manage costs effectively across our most expensive programs, which are investigations and discipline. And we're doing a lot of work with respect to that to make sure that we are as efficient as we can be with the fees that are collected. Any other questions?
Earlier on, I don't know what slide it was, so I'm just gonna, under regulatory excellence, you noted a thing on future accreditation. In a conversation I had with a great OSCE prep person called Joanne Baker, curriculum is the school's job ensuring that they meet interjurisprudent, can't read that one, competencies. The college, the college, not the colleges, you're not responsible for I can't say that word today. Interjurisdictional competencies.
Well, we participate in the development of interjurisdictional competencies because they form the foundation of the exam and the entry to practice requirements. So we are a member of FOMTRAC, which is the group that involves, I think it's the 5 regulated provinces where, Angie is telling me yes, the five provinces where massage therapy is regulated. And a great deal of work has been done to develop a consistent set of competencies that inform education everywhere across the country. So, because we do want consistency of practice, particularly if people are going to move from jurisdiction to jurisdiction. So,
Because I've been graduated for over 25 years, and I do believe to this date, one of the number one things, quoting Facebook again, that comes up is trigger points. I, as a fascial specialist, obviously have a different perspective on that. But I find numerous of our competencies are based on scientific observations and facts, neurology, the psychology of pain, fascial tissue itself. Nobody is teaching on those topics, and seems to have drastically changed in the last 25 years.
so that's a good point. We have, for sure, the last time the PC's PIs were updated, and I cannot remember what that stands for, but they are basically the competencies that you're referring to. The last time they were updated was, I think, in 2016, so that they are on the list of things that FOMTRAC wants to address in terms of updating, because you are not the only person that I've heard from over the course of these open houses who speaks to the fact that that foundation for the educational curriculum does need to be updated. So that's for sure something that we're thinking about. Okay, and if that's it, I'll just thank you again for attending, and thank you to those on the live stream for attending. And again, you can send your questions if you have additional ones to the email that we have set out here, and happy to speak to anyone after as well. Thank you.